and we'll go over to the next talk. The next talk is by Dr. A.S. Soin, who's the Chief Hepatobiliary and Liver Transplant Surgeon and Chairman at the Medanta Institute of Liver Transplantation and Regenerative Medicine at Medanta-The Medicity. And he'll be talking on outcome of ABOi liver transplantation, the Indian experience. Dr. Soin, please.
Thank you very much, Pankaj. And thanks, Sanjeev and Subhash, for organizing this and inviting me to talk here. And thanks, Hiroto. Professor Egawa has spelled out the problems with AMR very nicely. He's, of course, a renowned world expert in this field. And I've actually got some overlaps between the last two talks and mine. So please bear with me, but what I'll do is I'll take you through what our protocol is and what our experience has been. And here it goes. Let me start sharing the screen. Yeah. You can all see my screen, hear my voice.
Yes, we can see you, see your screen. And if you put it on full screen, yeah, that's fine.
Okay, so the problem with ABO incompatible liver transplantation is, of course, the antibody mediated rejection, which you already heard. Basically, it means in the clinical sense that there will be hepatic necrosis, especially in those who are older than 8 years. There'll be markedly elevated enzymes, there'll be necrosis CT. You saw the CT films that Dr. Egawa showed you. And this usually happens a week or two after liver transplantation. The second dreaded problem with AMR is, of course, intra-hepatic biliary complications, which basically means there'll be refractory sclerosing type cholangitis on cholangiography, and this typically happens 1 to 3 months after liver transplantation, sometimes even much later. So I'm actually going to split my talk into a quick look at how you select patients and pre-transplant optimize them. And then a little bit about immunosuppression, because this single theme conference actually focuses on immunosuppression and then post-operative management and outcome. So in the preoperative phase, I'll tell you what we do with recipients who have ABO incompatible living donors in our situation, and then talk about recipient selection specifically in relation to how sick they are. That means high MEL patients, patients who have PSC, which Hiroto clearly said is a difficult group of patients, patients with HCC, because it is often thought that patients with HCC will do worse with ABO incompatible liver transplantation, and we'll see if that's true. And then, of course, a quick word about optimizing these recipients before surgery. So when we have an ABO incompatible living donor, if it's a A to B or a B to A type of incompatibility, we generally put them in our swap database, and 80% of the times we are able to match them with the opposite pair and are able to do a swap transplant. If there is a A to O or a B to O or a AB to O type incompatibility, then these are the guys who actually need ABO incompatible liver transplantation, except for a minority who can actually have a volume swap. Now, who are the ideal recipients and donors in these cases? An ideal recipient should not be very sick. It should be an elective transplant, MELD ideally less than 22. They should have a good performance status. Their renal function should be good, and there should be no serious sepsis, of course. It is ideal to exclude advanced HCC, and but within UCSF, HCC would be acceptable. PSC and PVC may have more predilection to more AMR, but that doesn't mean that you don't do that. An ideal donor is obviously young, with a GRWR of 0.8%, more than 0.8%, and does not have any steatosis in their liver. And good combinations to do this are A2 to O, where, of course, the immune reaction is very minimal, if at all. But the problem is that we in India hardly have any people with A2 blood group. In recipients in whom CD19 counts are less than 50, CD19 counts are surrogate markers of CD20 positive cells. And in those in whom the initial anti-A or B antibody titers are less than or equal to 1 by 256. Now let's look at HCC. The evidence from Korea, and I've got 3 papers here, and one's a National Cancer Center, and they've shown that the ABO incompatible liver transplantation has no adverse impact on oncological outcomes in patients who are transplanted for HCC. And then the Samson Medical Center have shown the same thing. And of course, the Asan Medical Center, at this time, they had close to 300 patients that they published, but currently they have done more than 500 ABO incompatible liver transplants. And they've shown that the overall and recurrence-free survivals in patients with HCC are comparable between those who have had compatible and incompatible LDLTs. So, as long as the recipient is within UCSF, you're okay doing a patient with HCC with an incompatible donor. In terms of pre-liver transplant optimization, I would optimize their renal function, I would make them recover from sepsis, and I would downstage the HCC if it is beyond UCSF. Now let's look at immunosuppression pre and post liver transplantation in these cases. Now, the whole point of immunomodulation and then subsequent immunosuppression in these patients is to either clear the pre-existing anti-A or B antibodies or prevent their production. And you can clear them by total plasma exchange or TPE. And you can decrease their production by doing a splenectomy or giving them mycophenolate or other anti-metabolites. And of course, by administering anti-CD20 antibodies, which is rituximab. You've seen a similar cartoon in the earlier talk. So these are the various steps of how the antibodies form and then interact with the endothelium. And in turn, there is arterial thrombosis and destruction with the complement activation. And of course, release of pro-inflammatory cytokines. And these are the strategies to preemptively treat AMR or prevent AMR, which means administration of rituximab, doing a splenectomy, because spleen is where the B cells mature into plasma cells, which actually make the antibodies. Plasma exchange to clear the pre-existing antibodies, IVIG to competitively neutralize the attachment of these antibodies to the endothelial cells, and so on. But these 4 are the major strategies that we use. Now, rituximab is, as you all know, is an anti-CD20 antibody. And it basically acts on most of the B cells and plasma cells to inhibit them through complement-mediated cytotoxicity, through ADCC, and by direct lysis and or activation of the apoptotic pathway. Now, the aim of pre-transplant immunomodulation is that you should administer rituximab to get a CD19 count of ideally 0, which I told you is a CD20 surrogate, or 1. And this typically happens somewhere between 10 and 20 days. And do plasma exchange to be able to get anti-A or B antibody levels, IgG and IgM, less than 1 by 1/6, less than 1 by 16. Dr. Egawa showed you this nice paper of his where he talks about the survival among patients who received rituximab more than 185 milligram per meter squared versus those who received less. And it's clearly the cutoff where patients start to do well. And most of the people now administer 300 to 375 milligram per meter square 2 to 3 weeks before the planned transplant, and then start MMF and tacrolimus a week before, and give total plasma exchange 1 to 3 sessions. And then post-operatively and intraoperatively, we don't really do any splenectomy. There is no local infusion. And post-operatively, you continue with TAC, steroid, and MMF. And the differences from ABO compatible transplantation are that intra-op, we would give higher doses of prednisolone at 15 milligrams per kilogram instead of 10. And I would give higher dose of steroid post-op at 1.5 mg per kilogram for the first 3 days, followed by 1 mg per kilogram for 2 weeks, as opposed to just 1 mg per kilogram for 5 days and then taper. MMF and then tacrolimus is again kept initially for the first 4 weeks at 2 higher than it is in the compatible transplant, and then later on perhaps 1 higher. This is usually 5 to 7 for compatible transplant. So a little bit higher immunosuppression is what we would go with. And we would monitor the anti-AB titers, IgM and IgG, pretty much every day for the first couple of weeks, and then alternate days in the next 2 weeks, and keep them low. And CD19 counts are monitored really more for academic purposes, and we would do that up to 3 months. Now, a word about emergency liver transplantation. That means recipients who have ALF or ACLF, can they actually have ABO incompatible transplants? We've only done 1 successfully. So what would we do? We would confirm the liver transplant that is happening, confirm the donor, then administer rituximab as soon as possible before giving as many days as possible before the transplant. Delay the transplant for 5 to 7 days if possible using CRRT. And then you give plasma exchange 2-3 times, up to 5 times to attain the right anti-AB, IgM and IgG levels. And then give IVIG at 0.8 grams per day, like 2 days before and 5 days afterwards. And then the usual ABOi doses of tacrolimus and MF. Try and give them before the transplant as many days as possible. So many would do a splenectomy. We did not do a splenectomy in our single case because, like I said, that's where the B cells mature. And like Dr. Egawa said, you either bleed the recipient out during surgery, or if the blood loss is not too much, then a lot of people prefer to do splenectomy, especially in the emergency situation. And post-transplant immunosuppression, same as in the elective cases. And then now a word about post-operative management, AMR diagnosis, treatment, and outcome. I will skip the AMR diagnosis and treatment. You've just heard that. But what I would say is that we basically look at AMR. We suspect AMR whenever there's an elevated LFTs, especially when accompanied by raised anti-ABO titers, and when the donor-specific antibody titers are more than 5,000 MFI, and when the histology shows periportal edema, necrosis, arterial thrombi, and C4D staining. There are BAMP criteria for livers with AMR, and basically, if you have the features we just described with a positive serum DSA and exclude other causes of liver damage or dysfunction, then you've got a AMR at your hand. And again, the way to counter that is bortezomib, plasma exchange, IVIG, and IL-6 inhibitors. And what we would do is treat them with steroids, IVIG, total plasma exchange. We haven't done bortezomib. I'm not sure what Dr. Egawa's experience is with this. There are some anecdotal reports that it works wonders. So the outcome, like I said, after ABO incompatible transplantation, especially by experienced centers, this is again data from Professor Song, shows that they have excellent survivals after incompatible transplants, just the same as compatible transplants. And I'll take you through. So just a little word about our protocol. What we do is I've already said what we do with the CD19 counts and the measurement of the IgG and IgM antibody levels. But we would not give rituximab to children less than 5 years. We would just treat them with plasmapheresis pre-op with or without MMF, and electively give IVIG if we've only given plasmapheresis. And the rest of the management tends to be the same as in adults, which I just showed. Out of our nearly 3,539 transplants. We've done 28 ABO incompatible transplants. The ICU stay has been 5.4 days, hospital stay 17 days. AMR, it happened to 2 patients. One responded to treatment. We lost the other patient. ACR 5, that's 17%. Vascular complications, HAT in 1 patient, that's 3.5%. Biliary complications, 14%, which is slightly higher than about 9.5 to 10% that we have in ABO compatible transplants. 90-day survival is 82%. We lost 5 patients early, and 1, 3, and 5-year survival at 82, 77, and 74%. So I'll summarize here one by one the 3 sections that I've talked about. As regards to selection and pre-transplant optimization, I would do a ABO incompatible transplant if swap transplant is not possible. Ideal would be a stable recipient with a MELD less than 22, an HCC with an UCSF, no sepsis, good donor liver, and low anti-AAB titers. And I would optimize recipients by treating their sepsis, renal dysfunction, and downstaging their HCC if necessary. And then about the peri-transplant immunosuppression, I would give anti-CD antibody for B and plasma cell suppression. And I would remove the circulating antibody with plasmapheresis. Rituximab dose 300 to 375 mg per meter square 2 weeks before. Tacrolimus and MMF from day -7. TPE 2 to 5 exchanges to make the levels of IgG and IgM at 1/16 or less. We haven't done so, but I would consider splenectomy in emergency cases, and IVIG, yes. And post-transplant immunosuppression is slightly higher than compatible transplants. As regards post-operative care and outcome, post-op AMR is the main potentially serious problem. And I would suspect it if the LFT and anti-AOB titers are elevated. I would confirm by DSA titers and biopsy. I would treat with steroids, IVIG, total plasma exchange. We don't have any experience with bortezomib, but possibly that should be used. And post-operative complications are similar to compatible transplants, but there is, of course, a higher intra-hepatic biliary complication rate. And elective ABOi outcome is similar in experienced centers to ABO compatible LDLT. And I believe it can increase the live donor pool by 30%. Thank you very much.
Thank you, Dr. Soin. Thank you for that crisp and wonderful talk. And if we have a co-chairperson, Dr. Vikram Raut, would you take over the question and answers, please?
I think while Vikram comes in, I must thank all the 3 speakers for a really, really good quality, lectures, insightful talks. Special thanks to Dr. Egawa, who's been actually live with us and has promised that he will be here with us for the question answer sessions. So I think with these 3 talks by Dr. Soin, Dr. Egawa, and Dr. Shalin, if we have the opportunity of asking questions, we'll be happy to go for that. We'll have some time for that.
Can I ask a question?
Sure.
Yeah. Professor Egawa, I enjoyed your AMR talk as always. What is your, you have suggested that bortezomib should be used early. Is there a large experience in the world with the use of bortezomib?
No. So this time, that is in my first case. So I prepared, but I didn't meet the case. But this time, I had the experience. And so I have some company, for example, the Professor Oda in Hiroshima. He also had 1 cases in the liver, but he had some cases in kidney AOB incompatible. So we did not have a severe side effect of bortezomib. It's a safe medicine and not expensive so much. almost at the same price and rituximab in Japan. So it's easy to use and also definitely kill the plasma cell. So the titer decrease absolutely. So that in my case, I wanted to use the bortezomib earlier, but the hospital policy did not allow me to use the timing. So I used the rituximab and the IBIZ again. I mean, not again, IBIZ after transplant, but it worked, very worked. The decrease, but the maybe the severity of the AMR was too strong to replace by rituximab and IBIZ. So if I meet the if the steroid pulse did not work, and the patient had continued to have the fever and the CRP, high CRP, I use bortezomib.
Thanks.
We have one question from Dr. Subhash.
I'm just wondering whether MR imaging will help in detecting antibody-mediated rejection. The reason why I ask is it's been used a lot in cardiac transplant now, MR imaging. And certainly we find biopsies in somebody who's unwell, certainly with, the sort of percutaneous biopsies, trans-hepatic, although we have the expertise for it, we find biopsies a bit difficult to do. I know what others feel about it, Professor Gavan, Dr. Soin, and Dr. Shaleen. We find biopsies, and we've tended to rely a lot on MR images. And sometimes it does pick up sort of areas of necrosis and edema and periportal cuffing. And we use that for sort of changing a treatment regimen. So I just wanted a view from all the experts who are here on whether it has a role or whether, it could help. Yes, biopsy would be the gold standard, but sometimes it's just too difficult to do.
We have no experience with MR to diagnose rejection, but yes, of course, if you were if the patient was at a stage where you were suspecting an intra-hepatic biliary complication, of course, MRCP would obviously help.
So I would like to share because I've been working with Dr. Gupta for a long time, and that I've seen that, it may have a corroborative evidence, like when you're clinically suspecting that this could be rejection, when you see rising titers, deranged enzymes, patient otherwise clinically well, worsening cholestasis, and if your MR additionally shows some area of liver necrosis. So I think it's a corroborative evidence. And when you don't have the patient situation is not that, like you don't want to do or risk the patient with a liver biopsy related complications. So it may add to your suspicion of AMR, and you may proceed with the subsequent management on those grounds. So I think definitely there is an element of changes, especially areas of necrosis that you see that MRI may be helpful in such situations.
The cardiac transplant guys use a lot of MR nowadays.
I'm saying the MR changes might be late now, Shaleen.
Yeah, that is true, sir. That's true for but we are talking of situations where you want to avoid a liver biopsy. So this is, I'm not saying it's a corroborative evidence. So necrotic areas definitely may appear late. By that time, I think already AMR.
Even edema you can see, not just necrosis. Periportal cuffing is quite, I don't know, the cardiac guy seems to use a lot of MR imaging in diagnosing rejection nowadays. Cardiac MR.
The periportal edema that we're talking about is on histology. I'm not sure if it appears on gross imaging.
I wonder if Dr. Igawa has any experience with use of MRI?
What you mean is a diagnosis for biliary complication. You mean MRI means that? Yes, we use MRI for the diagnosis of biliary complication secondary to AMR, but it is too late. So the biliary complication means that it cannot to save already. So before the patient develops biliary complication, I mean stenosis, we have to save the patient by anti-inflammation treatment using the early diagnosis of the liver biopsy.
So in our experience, transjugular liver biopsy is possible almost in every case. So
Yeah.
I would
The
go
key
for
is usually day five.
I would go for a biopsy at a very low threshold in an ABOi. It's better to find a normal biopsy than to delay the biopsy.
No, I think the reason for raising this question I probably was because, as Dr. Gupta said, that in cardiac transplants, they're using MRI, but I think there is a very standardized picture of myocarditis on a cardiac MRI, and that's why they are relying more on it. Whether hepatic changes or hepatitis before full-blown AMR sets in can be viewed on the MRI. So I think we need more studies, and we need to standardize those changes of hepatitis as they have done so in myocarditis for cardiac transplant. So I think it is an extrapolation from that, and maybe it's a useful or an interesting area of further research.
Yeah, cardiac AMR is very interesting area.
Dr. Subhash, you had a hand raised.
Yeah, no, I just asked my question. I should lower my hand now, I guess. But I think we've used it a lot, I must say. And day 5, we all have, and in fact, they will get a steroid bolus in our unit on day 5, irrespective of titers and the values. I've done a huge number, actually. We've done 70 cases. And nowadays, in fact, everyone's familiar with the protocol. But we really found MR helpful in number of occasions. It tells you sort of collections, it tells you bile ducts, it tells you middle hepatic vein, right hepatic vein. And in 1-2 cases, I remember we picked up areas of geographical change on the MR. It's not MRCP, that is for biliary complications. We're talking MR of the liver, which is slightly different from MRCP. And you do pick up changes, and you do sort of help aids in the subsequent management. But even if you did a biopsy, by the time it gets reported, it may be too late. So on one hand, the MR changes may be late, but the biopsy changes may be early. But by the time the report comes through, one day you do a biopsy, the next day probably the report comes in. I think in Birmingham, they used to give us the report the same day, but I don't think any other unit in the country, maybe Medanta is different, they report the same day, but we do not get the report the same day.
Yeah, we are lucky to get the report within 6 hours. It doesn't matter what time of the day.
So we need a quick liver biopsy, at least 1 day.
I think since we are running late, we should now wind up the session. Thank you, everybody, for
Thank you very much.
And wonderful deliberations. Thank you, sir.
Yeah.
Thank you.
I'll hand over the mic to the organizer.
See you next time.
See you next time, sir.
Yeah, I was personally thank Dr. Egawa, for being here, and as promised, he stayed with us for the live question. Thank you, Professor Egawa, once again. Thank you very much.
Yes.